So the head should be supported by a pillow to make sure that the neck muscle is already relaxed. And once you start with the inspection, so you don't just inspect the patient, you also do an inspection for the surrounding. So instead of just having a tunnel vision where you just look at the patient, you should also look at the surrounding of that patient. Look if there is any oxygen that's next to the patient. Look if there's oxygen mask. Look if there is nebulizer. Look if there is non-invasive ventilation, like a CPAP or a BiPAP or the machine just next to the patient along with an oxygen mask. Look if there is a sputum cup just in the next to the table of the patient. Look if the patient having any IV solution, if they are having cannulas, if there is any blood pressure cuff at their arm. So like many things you can pick by just looking at the surrounding. And when you look at the patient, again, look how the patient is sitting. So you already put the patient in the 45 degree, but is the patient is able to sit in a 45 degree and just lying comfortably in the bed? Or the patient, even in 45 degrees, says, I'm not able to do that. I'm having shortness of breath. I have to sit because of the shortness of breath. And again, look at the general picture of the patient. And usually when you do the inspection, you should start at the end of bed. Like you do general inspection by standing at the beginning, at the end of bed. And then you look at the patient, look how they're sitting, look at their position, look at their breathing pattern. Is the patient is breathing heavily? Is the patient is tachypneic? Is the patient on distress? Or they're feeling just comfortably and they're sitting in their bed, lying down, and they're just waiting for you to do the physical exam. So this is like a very important sign that you can pick by just looking at your patient. Again, when you're looking at the patient, you can also count the respiratory rate. But when you're doing that, you should not draw the attention of your patient. There you're counting their breathing rate. Like you can't just stand and stare on them and looking into their chest movement, because some of our patients will feel anxious and they will start to hyperventilate from the anxiety, and that will increase the respiratory rate. So some way to do that is by just distract your patient. So you can, for example, or the common example for that, like you are pretending that you are checking their pulse, but actually you are looking at their respiratory rate and counting that. And you don't have to do like a full minute to count the respiratory rate. You can just count the respiratory rate over 15 seconds and multiply that by 4. Then you will have the whole hour. So again, you just go to at the side of the bed. You are pretending that you are checking the pulse, but you're not checking actually. You're not counting the pulse. You are counting the respiratory rate. And who can say that what's the normal respiratory rate for our patients? For a normal patient, 12 to 20 is a wide range. No, it's actually 12 to 15. So 12 to 15 is actually the normal range for the respiratory rate. Some anxiety can increase the respiratory rate up to 20, but anything above 20 is for sure is abnormal. So 12 to 15 is the normal range. It can be up to 20. Anything above 20 is absolutely abnormal. You can say the patient is tachypneic. And then when you are at the end of the bed, you can look if there's any scar in the chest, if there's any chest tube is going out from the chest wall, if there's any skin abnormality that you can pick from from a distance. And also you should look if there is any deformity. We have the different deformity that you can see in your patients. The picture on the left side is an example of how kyphosis or cervical kyphosis usually present. And why it's important to pick or to see the chest deformity? Because we know if a patient has deformity like silicosis or kyphosis, then you know that there is a restriction in the lung. So the chest wall won't expand during inspiration as it should be in a normal situation. And that would cause some restriction in the lungs. So you will have restrictive lung disease. So again, scoliosis or kyphosis. So a patient can have scoliosis or kyphosis or can have both kyphosis. Another deformity that you could see or is the pictus excavatum and pictus carinatum. Pictus excavatum is the one on the left. So you can see that there is some groove at the lower part of the chest. And most of the time, this is a congenital disorder. You don't see that a lot in our population. But if you see that, then know the name of it. It's pictus excavatum, and it usually presents due to a congenital disease. The other picture, the one on the right side, is pictus carinatum. And what happens in pictus carinatum is usually happen in a patient who have chronic obstructive lung disease during the childhood. And the reason behind that is because during inspiration and expiration, if a patient has an obstruction, then we know that the obstruction will cause the narrowing. And the air during inspiration will go in. But during the expiration, because we already know that the bronchi should narrow during the expiration, and if you already have pre-existing narrowing, then you will have more and more narrowing. So the air won't be able to exit the bronchi. With time, the air will build up in the lung parenchyma, and that will cause the lung to hyperinflate. So the lungs will be very big, and your patient will try to accommodate for the trapping of the air in the lungs. So they're trying to breathe more heavily in a way to get rid of any air during the expiration. And as we all know, we have the inspiration phase, which is usually longer than the expiration phase. But because we have narrowing, then the patient needs more prolonged time during expiration to get rid of the extra air. So some patients will have a sign that we call a pursed lip sign, in which they will take the inspiration normally, but when they do the expiration, they will do it like this, with inspiration and the expiration. And by doing that, the pursed lip sign, usually they extend the expiration time in a way that they can overcome the obstruction and get rid of the get rid of the air. During the inspiration and the expiration, you will have, this is your chest cage, and then you will have inspiration and expiration, inspiration and expiration. But when the lungs are already hyperinflated, then the chest wall will have abnormality. They usually will go upward and outward. So when you go upward and outward due to the use of accessory muscle, usually the use of sternocleidomastoid and the use of the intercostal muscle just to overcome the obstruction, then the clavicle will be pulled up superiorly, the same thing for the shoulder girdle. Then the chest cage will be upward and outward. Again, the diaphragm will be flat, and you will have an inward for the lower ribs during inspiration instead of outward movement of the lower rib during the expiration. So at the end, you will have a patient with this picture, and you can tell that this patient has already increase in the anterior posterior diameter for the same reason, because you have the chest wall having moved upward and outward for a prolonged time. And you can look at his clavicles, and you can see the clavicles already pulled superiorly at the same at the same time, the shoulder girdle is also pulled superiorly. This is a typical example and a typical picture for a patient with chronic obstructive lung disease for a prolonged period of time, and doesn't happen like just over a few months or like a few years. It takes prolonged time for the deformity to happen. So it's very important to pick those chest deformities when you do the inspection at the end of the bed. Sometimes you have to do an examination at the anterior chest, again at the posterior chest, because the kyphosis and the scoliosis, sometimes it's hard to tell from the anterior chest, so you should look at also at the back of your patients. So you're done with the inspection or the general inspection. You have already have an idea of what your patient has, and then you will go to the side of the bed. Again, we are doing the respiratory system examination. We're not just doing a chest exam. So when you go to the side of the bed, then you look at their hand. So the first thing that you look at is the fingernails. Look at the patient fingernail. Are they normal or are they abnormal? And what exactly we're looking at is something called clubbing. Clubbing is usually due to overgrowth of the soft tissue in the distal phalanx. So when you have the overgrowth of the soft tissue, you will have increase in the curvature of the nail bed, and you will have a picture similar to this one. And the way to examine that is by asking your patient to bring both fingers together and look if there is any space between the two fingers. If they have space, this is a normal finding. But if they don't have a space, then that means that the patient is having clubbing. You try that and see if all of you have a space between your fingers or your fingernails. Yeah, you just do it. All of you have a window in between or no? Does anyone not having any space between their fingernails? So even though that we say clubbing is an abnormal thing, some patients will have a congenital clubbing. It means that they have clubbing, however, they don't have any underlying disease, they just have the clubbing. And another way to do the clubbing examination is by looking if there is a fluctuation at the nail bed. So you can just hold their fingers and look if there's any fluctuation at the nail bed. Who can give me an example where the clubbing can present due to respiratory disorder? Yes. COPD. This, okay, they're not agreeing with you. How many would say that the COPD can present with clubbing? 1, 2, 3. Okay, 4. Who says that clubbing does not present in COPD? No? Okay. So do you agree that the most of the patients won't present? Case by case. So most of the patients who won't present, it's unlikely that COPD patient will present with clubbing. So if a patient has chronic cough or is having shortness of breath, and in physical you find clubbing, then you don't put COPD at the top of your differential. Actually, you put it at the bottom of the list, because it's less likely that a patient with a COPD actually present with the clubbing. But as everything in medicine, there's never like always, and there's never in our medicine. So some of the patients, even if they're having COPD, they will have clubbing. But the general rule that usually patient with COPD does not present with the clubbing. Give me another example. What's that? شو هي؟ Popcorn? Popcorn lung, what's that? What's the disease causing the popcorn lung? Lung cancer. I'm not sure if lung cancer can cause the popcorn. So lung cancer can present with the clotting, yes. ARDS? ARDS is less likely to present because ARDS is an acute disease and usually a life-threatening, a fatal disease, so it's unlikely. We usually, what can cause clotting is more like chronic illnesses. Cystic fibrosis, yes. Cystic fibrosis. Bronchiectasis. Emphysema is the same as COPD. COPD, we used to say chronic bronchitis and emphysema, but now we don't say that anymore. We just say COPD. Infective endocarditis, okay, I just asked in the differential about respiratory disease. But yes, infective endocarditis can present with clotting, yes. Lung cancer, we say that. Celiac disease, celiac or inflammatory bowel disease can also present with clotting, but again, I'm just talking about the respiratory disease, yes. Bronchiectasis, we already mentioned that. TB, okay, what else? Liver cirrhosis, again, that's true, but we're talking about respiratory diseases. Lung abscess, what else? Yes. What's that? Can't hear you. Interstitial lung disease. Liver cancer, lung cancer, we mentioned that. So lung cancer, lung abscess, cystic fibrosis, bronchiectasis. Did I mention lung cancer? I think I did. What else? Lung fibrosis. What did you say? Pulmonary fibrosis. Lung fibrosis is the same as pulmonary fibrosis. Cyanotic congenital heart disease. Okay, cyanotic congenital heart disease. Yeah. Again, it could be due to pulmonary cause or extrapulmonary cause. Extrapulmonary, most of the mentioned the liver cirrhosis, IBD, inflammatory bowel disease, celiac disease. They can also present with a clotting. So clotting doesn't mean that your patient have only pulmonary diseases. Also, extrapulmonary diseases can present with that. But remember that lung fibrosis, lung cancer, lung abscess, cystic fibrosis, bronchiectasis, all of them can present with a clotting. COPD is less likely. Smoking, how about smoking? Actually, it does. Smoking can cause clotting. So you are done with the finger clotting. You also look at the color of the fingernails. There is a syndrome. I don't know why everybody likes this syndrome. I've never seen it. I don't think you will see it either. But anyhow, you should know it. I don't know why, but you should know it. The yellow nail syndrome, in which the patient will have a yellow nail and they will have a pleural effusion at the same time. They call it the yellow nail syndrome, and you can see it a lot in the books. You look at the fingers, you look at the fingernails, and you look if there's any staining in their hand. Mainly if there's any tobacco staining. Again, smoking is a risk factor for most of the respiratory diseases. So you will always have to look if there's any staining from the tobacco. And you look if there is peripheral cyanosis, and we usually look on the peripheral cyanosis in the fingers, and look if there's wasting in the hand muscle, in the thinner and the hypothinner muscles. Usually patients with a lung cancer, usually if they involve the T1, then you will have wasting in their hand muscle. And examine if the patient has any tremor. And we have two forms of tremors. We have fine tremors, and we have the collapsing, the coarse flapping tremors. And it's more common to see fine tremors on patients with respiratory disease, especially the patient who come patients who are coming to the ED and you go do a physical exam and you can see the fine tremor. Can you, or any of you can give me a reason or can give me an explanation why a lot of our respiratory disease patients can present with fine tremors? Yes. The what? The beta agonist? Yes. So if you have a patient with a shortness of breath, or a patient with asthma or COPD, and they present to the ED. So what you're going to do is going to give them inhalers. Or even those patients, they will have the PRN inhalers in their pocket. So whenever they feel shortness of breath, they will take a puff or two. So it has a beta-2 agonist, and beta-2 agonist will stimulate the sympathetic system, and that would cause the fine tremors. Sometimes when you look at their hands, sometimes it's difficult to pick the fine tremors. So another way to do that, or like if you're doubting whether or not this patient is having tremors, then you can just ask the patient to extend their arms and just to extend their arms and just put a paper into their hands. And you can tell if there is tremors or if there's shaky movement of the papers. Another tremor that can present is the flapping tremor. And flapping tremor, you can pick that sign by asking the patient again to extend their arms and then extend their wrist. Their wrist has to be extended. Like you can't see the flapping tremor like a half extended or not extended hands. So they should be extended, and ask them to stay in that position for a couple of seconds up to a minute. And if they have the flapping tremor, the coarse tremor, then you will have the flapping sign. Their hands will start to go downward. So this is how you usually examine for the flapping tremor. Who can give me a differential diagnosis where we can see a flapping tremor? CNS? COPD? Okay, not all COPD patients, but it can present only if they have something. Yes. Liver failure. Okay, liver failure is actually the most common. And usually it's due to buildup of the ammonia due to the failure of the liver or liver cirrhotic patient, then they have the flapping tremor. How about the respiratory system? What diseases or what condition can cause flapping tremor? Severe asthma attack. Again, it depends. It depends on something. Something should happen to cause the flapping tremor and the respiratory diseases. Yes. Yes. So CO2 retention. So again, the what? Hypercapnia is the same term for the CO2 retention. So one of your colleagues said that the COPD. So not all COPD patients, only if the COPD patients start to have hypercapnia. Another term, if they have a buildup of the CO2, mainly acutely, then they will have the flapping tremor. The same for asthma exacerbation, life-threatening asthma exacerbation patient. If they are fatigued, if they're unable to hyperventilate, then, or they are losing their consciousness, they are very tired, so they can't keep up with the increase in the respiratory rate, then they will have a buildup in the CO2. And once you have CO2 retention, then you will have the flapping coarse tremor. Okay, so once you're done with the hand, then you will go to the wrist. In the wrist, you can look if there is any tenderness. Some of the patients will say, I'm having a tender, or like I'm having a painful wrist. And when you examine, actually, yes, the patient is having tenderness in their both wrists and also in both ankles. And you can ask the patient if they have a trauma or like if they fractured their wrist. And they say, no, like I didn't have any of that. And you do an x-ray and you find there is a new bone formation at the cortex of their long bone. And that usually what we call the hypertrophic pulmonary osteoarthropathy. And it's usually present in a patient who has a lung cancer. So if you see that in the physical examination, it's a red flag, it's an alarming sign. And it's usually, again, present in a patient with lung cancer. So go to the wrist, examine them, look if there is any tenderness. You can also check the pulse, and then you will be done with the hand and the wrist examination. Then you go to the face. When you go to the face, you start with the eyes, look at their eyes, look at their conjunctiva, look if there is any pallor in their conjunctiva that could explain the patient is having underlying anemia. And not only look at the color of their conjunctiva, also look at the eyelids, look at their pupils, and see if there's asymmetry between the both pupils. And look if the patient has something we call litosis or meiosis. And if the patient is having meiosis and ptosis, as this picture, the picture on the left side, you can easily say that there's asymmetry between the two pupils, and the patient has meiosis or like a small pupil in the left eye, and he also has ptosis. Where you have, look at the eyelid, it's like going downwards. So ptosis and meiosis also an alarming sign. And what we call this is the Horner syndrome. And who can say when we can see the Horner syndrome? Pancostal tumor. So if the patient has a tumor in the apex of their lung, then the sympathetic plexus will be involved, and that would affect the innervation for their eyes, and they will have ptosis and they will have meiosis. It's a very common question that you usually see a lot in the exams. Even like if you're doing USMLE exams, they ask about the Horner syndrome a lot. And then you look at their face, you look at their mouth, you look for central cyanosis in their tongues and their mouth. They have any central cyanosis. Again, you look for the peripheral cyanosis in their fingers, and you look for central cyanosis in their mouth and their tongue. Once you're done with the face, then you go to the neck. Who can give me some findings that present on the picture on the right side? Just describe what do you see. Red face, so there is some congestion on the face and the neck. It's not just the face that's congested. You can tell the face is congested, yes. Okay, so we have dilated veins. Again, we're only describing, we are not saying what's the differential diagnosis, just describing what you see. So we have dilated vein in the upper chest, and you also have dilated vein in the abdomen. It's not just the upper chest. Yes. So the swelling is mainly in the upper part of the body. So it's mainly in the neck, the upper chest, and the face. Okay. Who can give me one differential diagnosis when you can see this? Yeah. So superior vena cava obstruction is like a typical picture of how usually superior vena cava obstruction can usually present. And if you think the reason behind that, so we know the superior vena cava is like draining blood or like doing the venous return back to the heart. And if you have obstruction in the superior vena cava, whether that obstruction due to the lung tumor or whether that obstruction from narrowing in the vessel from, for example, catheter insertion, especially patient with dialysis who needs a lot of dialysis catheter in the upper chest, that eventually will cause narrowing in their veins, then eventually you'll have obstruction in superior vena cava. So you know the blood can go back to the heart. Then the body has to overcome that. So we'll have the collaterals. They will have the dilated veins are actually the collaterals. So in a way, they're trying to return the blood back to the heart other than the superior vena cava. And since the blood, not all the blood will come back, then we'll have most of the blood will be built up in the upper part of the body. So you will have the congestion in the upper chest, you will have congestion, as in this patient, in the neck and in the face. I think we discussed that. Okay. So again, in the neck, we are not just looking at the dilated veins. You also look into their JVP. You look if their JVP is distended or not. Can you give me an example for distended JVP? Any ideas? Your friend who's sitting next to you. No, just the one next to you. Can you give me an example of distended JVP? JVP. Severe hypertension. That's incorrect. Pulmonary hypertension. That's correct. So it's not the systemic hypertension. You have to have pulmonary hypertension. Because if you have pulmonary hypertension, you will have hypertrophy in the right ventricle. And then the blood will go back, and that will cause distended JVP. Somebody is going to say something here? Okay. CBS. Portal hypertension is less likely to present. PE. So massive PE, if PE causing strain into the right ventricles, then again the blood will go back and that will cause distended JVP. Yes. The what? Pneumothorax. So massive pneumothorax or tension pneumothorax sometimes can cause distended JVP. Yes. Tricuspid stenosis. Okay. Anything that affects the right valve. Right side heart failure, even the left side heart failure can also cause distended JVP. So anything that affects the right side of the heart, whether causing right ventricular hypertrophy or you have a valve stenosis, then you would expect that those patients will have distended JVP. Cardiac tamponade. I'm not sure about the cardiac tamponade. I don't think so. So they will have the paradox of the JVP in cardiac tamponade. Yes, somebody was saying something here. No? Yes. PE. Yes, we already mentioned that. So other than the JVP, you also look into, again, we say dilated vein. You look if there is any enlargement in the lymph node. And when you examine the lymph node enlargement, you have to examine the patient from behind. Like you can't just do examination at the anterior neck to look for lymphadenopathy. You should stand behind the back of the patient and you examine for lymph node enlargement. Were you saying something? Okay. So you're done with the inspection in the neck and you look on something that we call, you look for the tracheal deviation. And the way you do that you put your index finger, some of the examiner will say the middle finger, but McLeod say the index finger. So you put your index finger at your sternal notch. And if you just press gently, you can feel the trachea just under your index finger. Try to do that now. Can you feel your trachea? Just like, it feels like there are some rings, yes. Yeah, but like sometimes it's hard to feel it until you press forcefully into the trachea. But all of you can palpate the trachea? Yes? No? All of you can palpate that? Okay, I'm assuming that's yes. So the trachea should be centered, in the center. If you do that, the trachea should just below your index finger. If it's not, then you will have a deviation of the trachea. and this is where we have the abnormality. So normally it should be in the center. When you do that, you should just find the trachea. If you do that but you don't find the trachea, you feel, oh, it's actually deviated to the right side, or it's actually deviated to the left side. So that usually the trachea deviation, it happens when there is abnormality in the right or left lungs. And whether the trachea is deviated to the same side of the lesion or the trachea is deviated to the other side of the lesion, you can tell by just doing that physical examination. So give me an example for deviation of the trachea to the same side of the lesion. Just, what's your name? Yes. Bassam. Bassam, can you give me just one differential diagnosis if you find the trachea is deviated to the same side of the lesion? For example, I'm telling you that the patient is having a right side lesion, and you do the tracheal deviation exam, and the trachea is deviated to the right side. Okay, that's to the opposite side. Yes. Lobectomy. So, yes. Lung fibrosis. It depends. Sometimes, like, depending on the goiter, is it more on the right side, left side? Most of the time, they can just keep the trachea at the same side. Yes. Atelectasis. So anything that would cause the lung to be small will deviate the trachea at the same side. TB is less likely, unless it's causing fibrosis and then you have shrinkage in the lung parenchyma. So again, anything that causes shrinkage in the lung parenchyma, then you will have a small lung. For example, you have small lung in the right side. So you have the normal left side of the lung. That will push from the normal side to the abnormal side. Then you will have deviation of the trachea to the abnormal side. So lung fibrosis, atelectasis, if you are losing part of your lung parenchyma due to collapse or due to lobectomy, then you will have a small volume of the lung on a certain side, and the trachea will deviate to that side. Bassam say attention pneumothorax. When you have attention pneumothorax, so if the lesion in the left side and you have tension pneumothorax, then you have pressure in the left side, and that pressure will deviate the trachea into the other side. So you will see even the lesion is the left side lesion, but you see the trachea deviated to the right side. Who can say another example for deviation of the trachea to the other side? Pleural effusion, yes. What else? Lung cancer. So it depends on the lung cancer. If it's like a huge lung cancer, mainly in the apical part. If the lung cancer is big, then they can deviate the trachea to the other side. The what? Trauma? Trauma is like if it caused pneumothorax, tension pneumothorax caused that, but like a simple trauma, it should not. Is it? Like dissection in the trachea? Well, if the patient has dissection, he will die right away. Most likely, yes. So it's very important to know what diseases cause deviation of the trachea to the same side or deviation to the trachea to the other side. Again, they like this a lot in the exam, and they ask a lot about this, whether it's in OSCE or in the theory. And then once you've done a look into the tracheal deviation, then you do or you measure the cricosternal distance. Usually it's the distance from the sternal notch to the cricoid, which is like the ridge in their trachea, and it should be around 3 fingers. If it's less than 3 fingers, it happens in a patient who's having hyperinflation in their lungs. So it's a patient with chronic COPD patients or patients who have uncontrolled asthma. Right. Okay. So we are done with the inspection of the neck. Then you will go again to the thorax. And again, you do another inspection, but this time you do an inspection from short distance. So you're looking if there is any signs that you have missed or you did not find at the site of the bed. Usually the scars that the patient has in the lateral side, for such patients having a video assisted or they have tracheotomy, the site of the scar usually in the lateral chest. Sometimes you don't see that when you're standing at the end of the bed. So again, when you go to the side of the bed, again, you should look and you should do another inspection. Look if there is, again, any dilated vein, look if there is any scars, look if there is any skin changes, and you can look if there is any tubes going in or going out of the chest wall. So you're done with the inspection, and now you will go to do the palpation. The first thing when you do a palpation, you should localize the apex speed. And it's similar how you localize it when you did physical examination to the heart. You do the same thing when you do a physical examination in the respiratory system. So at the beginning, you put your full hand in the most lateral and the most inferior part where the apex can lift, the apex speed can lift your hand. And once you do that, then you can localize that in 2 fingers. And then you measure if the apex speed is actually in the normal position, which should be in the mid-clavicular line, 5th intercostal space. And to know if this is the 5th intercostal space or not, you have to localize the sternal edge. So when you put your hand in your sternum, you can see that there is some bulge in your sternum, and that's the sternal edge. And the space that's just next to it is actually the 2nd intercostal space. So when you start counting from the 2nd intercostal space. Then you will count the 3rd, the 4th, the 5th, and you will look where is the midclavicular line, and that would be the normal position of the apex. This is how you do that. In patients who have hyperinflation, like patient with a COPD, sometimes it's very hard to palpate the apex speed. So if you can't palpate the apex speed, doesn't mean that you don't know how to examine that. It could be the patient is having actually hyperinflation in their lungs and that you can't palpate the apex speed. Once you do the apex speed examination, then you look for right ventricular heave. And you examine that by your palm, or you examine that by the palm of your hand. So you put your full hand in the right and the left lower sternum border, right side and left side. You put your you put your full hand, but you only examine through your palm. And if you feel there is some forceful pulsation, or like you feel that your hand is actually going up and down with every beat, and then that could mean that this patient is having a right ventricular heave. And anything caused hypertrophy in the right ventricle will cause right ventricular heave, and the common example on that is the pulmonary hypertension. So you did the apex speed, you did the right ventricular heave, and then you look for the chest expansion. And when you do the chest expansion, you put your both hands around the chest, and your fingers should be in the mid-axillary line, similar to the picture that you see here. And then you bring your both hands near to each other until both thumbs are just next to each other. And just don't press very forcefully in the chest wall so the patient can take enough breath. You just put them gently and ask the patient to take a breath in and out. And you can see if there is symmetrical expansion of the chest wall or not. If there is a collapse in the right side, for example, then when you do the chest expansion, then your hand in the right side won't go out the same as your chest in the left side, because you know that the lungs in the right side is already collapsed, so the inflation is not enough to bring the chest wall outward, so you won't feel that. So it's most important when you do the chest expansion is to look for asymmetry between the right side and the left side. And again, you do that for the anterior chest, and you do that again from the back. I have a picture for a patient who seems like maybe in the ED, or somebody could say in the ICU. I would bet that most likely patient in the ED. Who can describe this patient? Yes. Well, again, the same, your colleague also said angioedema. Angioedema is like a differential diagnosis, like it's hard to just say angioedema. I'm just asking you to describe things. I don't want you to give me a differential. Okay, perfect. So there's swelling congestion in their preorbital area, and there's swelling and congestion in the whole face. What else? Yes. Well, the picture can say that the patient has shortness of breath. Well, you can say the patient is on oxygen mask, right? So it's obvious that the patient has an oxygen mask. What else? Redness in the face. Does the patient look in distress, or does the patient look comfortable? In distress. So how about the position? Yes. I'm not sure if this is anaphylactic shock or not. It's unlikely. Again, I'm not saying that I want you to give me a differential diagnosis. I'm only asking you to give me findings, only to describe the patient. I don't know if this patient has anaphylactic shock, because if they have anaphylactic shock, I usually look at their blood pressure, and they're usually hypotensive. They could have swelling or the angioedema in their face, but again, I can't tell that from only just the picture. So the patient obviously is in distress. There's congestion in the face. There's redness of their face. The patient is oxygen mask. Look at how a patient is sitting. He's not lying flat in his back. He's actually sitting in the chair, in the bed, and even he's leaning forward. And this is common when the patient is having hypoxia. Usually they're trying to overcome the hypoxia by increasing the respiratory rate. They increase the work of breathing. So most of the time they will be leaning forward due to the hypoxia. And you can tell there is a port, multiple ports actually, for the oxygen supply. And this is the blood pressure machine. And you can see a blood pressure cuff on his right arm, and this is the EKG leads on his chest. Okay, so you can just describe things by only do a general inspection for your patient. So could this patient, who can give me a differential diagnosis now for this patient? Somebody say anaphylactic shock. Give me another differential diagnosis. Yes. Okay, allergic reaction, which is similar to anaphylactic shock. Yeah. The what? Insect bite. Okay. Hypertension alone? It's less likely. For like most of our patients are hypertensive, but you don't see many of them. Again, I say this patient is hypoxic because he's on oxygen. Why would you put a patient on oxygen if they are not hypoxic? There must be hypoxia. So just think about differential diagnosis that can cause hypoxia. Superior vena cava obstruction, okay. Pneumothorax, but usually pneumothorax won't be that sick. Even the patient is sweating. Heart failure. So heart failure is very common disease that you see a lot in the ED. So I would say this patient is having heart failure. He's having pulmonary edema. that causing the hypoxia, causing the tachypnea, patient is in distress, you already have a swelling in the face, and the patient is leaning forward due to that. Yes, somebody was saying something. Oh, this is the ECG leads, the ECG or the EKG leads. Yes. Pruritus? Epiglottitis. Epiglottitis more, we see that in the pediatric population. We don't see that a lot in the adult. Okay, what else? Pneumonia. Yeah, pneumonia can cause hypoxia, can cause tachypnea, can cause the patient to be in distress. COPD patient, patient with asthma exacerbation, patient with respiratory failure, whether it's type 1 or type 2. All of them, they will say, present with the hypoxia, patient will be in distress. All right? Questions? All right, thank you.